Thank you for joining us for the GAP MASLD MASH Community Network meeting tonight. My topic today is going to be MASLD basics. My name is Punam Punja. I'm a PA at Emory Healthcare in Atlanta, Georgia. I've been practicing as a PA for over 15 years, primarily in general hepatology. Please use this QR code to register for the meeting. And we'll start off by talking about the new name change. So fatty liver disease was replaced with steatotic liver disease. Steatosis just means fat buildup in 2023. So NAFLD was replaced with MASLD, which stands for metabolic dysfunction associated steatotic liver disease. And that can lead to MASH, which replaced NASH, which is metabolic dysfunction associated steatohepatitis. There was a new category that was formed, which was MASLD. These are for patients that not only have MASLD, but also have alcohol exposure as well. And based on how much alcohol they drink determines whether or not they have MASLD predominance or alcohol-related liver disease. And then there's alcohol-associated liver disease that adds steatosis in the liver. And then other etiologies, which include medications like steroids, tamoxifen, that can lead to steatosis in the liver, along with genetic disorders like Wilson's disease, LALD, and then other miscellaneous causes like hepatitis C, genotype 3, HIV, TPN, and so on. If there's not a clear indication as to what leads to steatosis in the liver, these patients are classified as having cryptogenic steatotic liver disease. So how do we diagnose patients with MASLD? So a patient needs to have some type of steatosis either on imaging or on liver biopsy. From there, they need to meet at least 1 out of 5 cardiometabolic risk factors, which I'll talk about in a few slides. And then if they have that and no other causes of steatosis in the liver, these patients can be classified as having MASLD. If patients meet all those requirements but also have alcohol exposure, then these patients are classified as having MASLD with alcohol and an overlap. If patients have steatosis on imaging, but they don't meet any of the cardiometabolic risk factors, you want to look for other etiologies, as I mentioned earlier, medications, purely alcohol causing steatosis in the liver. And then if there's not a clear indication as to what leads to steatosis, you think of cryptogenic disease. So how will this affect my practice? It shouldn't. Educating your patients is important about the name change. Let them know that MASLD replaced NAFLD and MASH replaced NASH. All recommendations that the AASLD practice guidelines give you on NAFLD also apply to MASLD and MASH. So going back to those cardiometabolic risk factors where you need at least 1 out of 5 along with steatosis on imaging or biopsy, the criteria include for non-Asians a BMI of 25 or greater, for Asian patients to have a BMI of 23 or greater, or an increased waist circumference. If patients have a fasting glucose of 100 or greater, or their hemoglobin A1C is 5.7% or greater, or they have type 2 diabetes or are taking medications for type 2 diabetes, these patients also meet those cardiometabolic risk factors. If they have a blood pressure of 130 over 80 or greater, or they're taking medications for blood pressure, they meet criteria. If they have a triglyceride level of 150 or greater, or they're taking a lipid-lowering agent, these patients meet criteria, as well as a HDL less than 40 for a man or less than 50 for a female, or they're taking medications to help with this. These patients do meet those risk factors. This excludes any patients that drink alcohol, and on average, about 2 drinks a day for females and about 3 drinks a day for males. So once you suspect that the patient has steatosis in a primary care setting, or even if they're seeing endocrinology, you want to risk stratify these patients and look for the patients that have more advanced fibrosis or scarring using non-invasive tests. So the FIB-4 index looks at a patient's age, platelet count, AST, and ALT. Based on that result, if it's less than 1.3 for anyone aged up to 65 or less, these patients can have their FIB-4 index reassessed by primary care team or by the endocrinology team every 1 to 2 years, especially if they have type 2 diabetes. If patients have a FIB-4 less than 2 for anyone age 65 and above, same thing, these patients can be reassessed every 1 to 2 years using the FIB-4 test. If the FIB-4 comes back at 1.3 or greater, these patients then need a secondary risk assessment done using a transient elastography or an ELF test, which is a blood test. If the transient elastography comes back at 8 kilopascal or less, or an ELF score of 7.7 or less, these patients can then use the FIB-4 index usually every 1 to 2 years. If their transient elastography comes back greater than 8.1 or their ELF test comes back greater than 7.8, these patients could be intermediate or high risk of having advanced fibrosis, and they should further be referred to hepatology to risk stratify these patients to look for at-risk MASH or cirrhosis. If a patient has a FIB-4 that comes back at 2.67 or greater, or they have persistently elevated liver enzymes, these patients also need to be referred to hepatology. So if you suspect that these patients have advanced fibrosis based on their transient elastography or an ELF test, you may want to consider a liver biopsy in these patients if they have non-invasive testing that's kind of all over the place, or there's diagnostic uncertainty, you're not 100% sure that this patient has just steatosis, or they have severely elevated liver enzymes, these patients should undergo a liver biopsy. If the biopsy comes back between stage 0 and 1, you want to see these patients every 2 to 3 years and reassess their non-invasive testing at that time. If patients have stage 2 to 3, which is halfway to cirrhosis and 1 stage before cirrhosis, you want to see these patients once a year and consider pharmacotherapy to help those patients that have MASH stage 2 or stage 3. For patients that have stage 4, which is cirrhosis, they now need to have cirrhosis-based management. If you suspect that a patient has cirrhosis, either clinically or on imaging, or an ELF test comes back at 11.3 or greater, these patients most likely have cirrhosis and need cirrhosis-based management. So looking at this global epidemiology of a publication that came out in 2023, the MASLD global prevalence is approximately 30% and increasing, which requires urgent and comprehensive strategies to raise awareness. So looking at the US population, there's approximately 340 million people in the US. About 60 to 80 million of those Americans have MASLD. Of those patients that have MASLD, about 15 to 20 million of those have MASH. And fibrosis progression rate on average in patients that get MASH is 1 stage every 7 years they go up. But there are some patients that are considered fast progressors and can progress to cirrhosis within 10 years. So once you develop fibrosis, anywhere from stage 1 to 3, these patients have a very small risk of developing hepatocellular carcinoma. Approximately 20% of patients that have stage 3 fibrosis over the next 2 years will develop cirrhosis. And from there, these patients can have high risk of developing HCC, high risk of liver failure, or liver death from the underlying cirrhosis. So there's a normal amount of steatosis that's already in the liver, but due to genetic factors, if they have a history of obesity, diabetes, any cardiometabolic risk factors, or alcohol use, these patients can then progress in their underlying MASLD and develop fibrosis over time, leading to cirrhosis and HCC. PNPLA3 is a common genetic finding that leads to MASLD and fibrosis over time. There is a gut microbiome bile acid alteration that leads to steatosis along with fibrosis over time. So it's important to remember that as well. I do advise my patients to avoid any processed foods to help with their underlying MASLD. So the AASLD in 2023, the key points that they state is that any patient that has MASH with F2 to F4 fibrosis noted on non-invasive testing or liver biopsy, these patients are considered at-risk MASH. They have a higher risk of liver-related events and mortality, and the rates of progression varies among patients. There are some patients that are very slow in progressing in their underlying liver disease and other ones that progress very rapidly. And this could be due to their disease severity, genetic factors, environmental exposures, and other cardiometabolic risk factors. I tell my patients that the biggest risk factor is cardiovascular disease and non-hepatic malignancies in patients that have MASLD without advanced fibrosis. Death from liver disease predominates in patients that have advanced fibrosis. So we'll talk about Mr. JP, who's a 55-year-old white male with a BMI of 35 that was referred to you because he had abnormal liver enzymes. He states he's gained about 20 pounds over the past 5 years. He has vague right upper quadrant discomfort. He says his liver enzymes are mostly normal, but for a male, the normal ALT level is on average is 35 or less, and for females should be 25 or less. So his ALT was at 45, AST was 50, his alkaline phosphatase and total bilirubin were normal. He is pre-diabetic with a hemoglobin A1C of 6.7 or 6.3%. He does have hypertension, which he takes lisinopril for. He has no known family history of underlying liver disease, rare alcohol consumption, and pretty sedentary lifestyle. He works in IT. On exam, you see he has central adiposity. It's important that we rule out any other underlying liver disease. You want to look for viral markers that can sometimes affect liver enzymes, along with checking a ferritin level, which can come back elevated in patients that have MASLD or MASH. But if the iron saturation is also up, you want to complete the screens and check for hemochromatosis. If patients have abnormal ANA or ASMA levels, check immunoglobulins. It's important to also check for HIV, lipid panel, hemoglobin A1C, and thyroid function, because all of these factors can lead to steatosis in the liver. And if there is any concern about alcohol causing steatosis in the liver or met ALD, definitely check a PEth test. You also want to get a complete abdominal ultrasound on these patients because it includes the spleen size. So when he undergoes a liver biopsy, an ultrasound, it comes back showing an increase in hepatic echogenicity with typical regions of fatty focal sparing. The contour appears smooth. His spleen size is normal, so he has hepatic steatosis and no evidence of portal hypertension. So which patients still need a liver biopsy? If there's any concern of more advanced fibrosis, especially if a patient is over the age of 65, or the non-invasive testing comes back, one showing no signs of advanced liver disease or another one showing very advanced, you may want to consider a liver biopsy in these patients. And also if you want to rule out any other underlying liver disease. So with our patient, he did have steatosis noted on ultrasound. He did meet 3 out of the 5 criteria. He had a BMI that was over 25. He had a hemoglobin A1C that was greater than 5.7%, and he's taking lisinopril for his blood pressure. All the rest of his workup came back negative, so this patient is diagnosed with having MASLD. So some of the questions that we need to answer is, does this patient have underlying MASH? We can't answer it based on the lab work and the ultrasound that we have. Having abnormal liver enzymes doesn't make a patient have MASH. So the gold standard is still liver biopsy looking for ballooning, inflammation, and fibrosis. Does this patient have any fibrosis? That's also a question we can't answer based on the laboratory data we got along with the ultrasound. It would be important to get a platelet count to be able to check a FIB4 test. And if that comes back abnormal, encourage the patient to get a transient elastography or ELF test done. And same thing, we can't answer, does this patient have advanced F3 or F4 fibrosis? Because we would need to start off with non-invasive testing with a FIB4 score and then move on to either a transient elastography, ELF test, and if you have access to an MRI elastography and or having the patient undergo a liver biopsy. So for more information about disease state education, please visit the GAP MASLD MASH Community Network using this QR code. We'd appreciate any of your feedback. Also can use this QR code to scan. And thank you. And please let me know if there are any questions.